I'd like to welcome everybody to Pediatric Grand Rounds today. My name is Patrick Healy. I'm Division Chief for Transplant Surgery here, and I'm excited to introduce our speakers today. We have two speakers. First, Andre Dick, who's a transplant surgeon, currently the interim surgeon-in-chief here. He's also Associate Professor of Surgery in the Division of Transplantation. He and Sarah Rasmussen, who I'm not sure how many people have had a chance to meet Sarah, but she came here last year. She's been here about a year. Sarah is also an Associate Professor of Surgery in the Division of Transplantation. She's pediatric transplant surgeon, came from the University of Virginia after training at pediatric surgery in Hopkins and surgery residency in Medical College of Virginia. So we're excited for this talk about really a innovative and interesting option in certain situations for transplant, and their talk is Domino liver donation, an important tool for increasing liver transplants. Thank you.
All right, good morning, everyone. Trying to move the slides here. All right, so we have no actual or potential conflict of interest in relation to this discussion. And as Dr. Healy said, we're going to be talking about domino transplantation today. And the way we're going to break up the discussion or the grand rounds is I'll talk a little bit brief overview about pediatric transplantation, a little bit about the history of transplant, as well as domino transplant. And then Dr. Rasmussen, who's the surgical director of liver transplant here, will talk about how to evaluate these patients, what are the surgical techniques that need to be done, what are the outcomes, and the future and the next steps. So the first liver transplant was done in the early 1960s, and at that time it was considered to be an experimental procedures, and that was over 5 or 6 decades ago. And today it's the treatment of choice for patients with acute or chronic liver disease, metabolic liver disease, or tumors. And today the 1-year patient and graft survival is above 90%. Transplantation has come a long way from experimental, as I said, to now successful. And this has occurred secondary to innovative immunosuppressive regimens, surgical improvement in surgical techniques, multidisciplinary care of patients, which includes not just the surgeons, but the hepatologist, social worker, dietitian, pharmacist, transplant coordinators. And on this slide, you can see the most common cause of liver transplantation in kids is biliary atresia, followed by metabolic liver disease. Now, these are all data from the SRTR, and this basically looks at how many pediatric patients are listed on the transplant wait list. And, over time, it's been relatively stable, but it's, anywhere between 1,000 and 1,500 patients on the list that are active. And how many patients are added to the list every year? And, it's close to, about 700 to 800 patients are listed every year on the wait list. And, this, if you're a candidate who is on the list the first time you come on, and, if your transplant fails and you need a retransplant, that's considered a new listing. And if you're listed at multiple centers, which you're able to do, your listing is only counted at once. So, just to sort of give you a background of what the active wait list looks like. And this looks at the number of transplants that are actually done per year. And, it's anywhere from 500 to 600 transplants a year. And the point of this slide is to show you, if you remember from the previous slide, is that, we have more patients being added to the list than actually transplants that are being done. And that's kind of the Achilles heel of transplant, is that there's more patients that need transplant, but there's not enough organs. So what does it look like on the list? As you can see, majority of the patients who are compromised, those patients on the wait list, are they're actually less than age five, with the rest older adolescent patients. And the waitlist mortality is primarily that burden is shouldered by the kids who are less than a year old. And some of those reasons are, again, we talked about organ availability. It's also a lot more challenging to find organs for little smaller babies. And when you do, it requires a certain level of surgical expertise in terms of the team to take care of these patients, because it's very difficult to find whole organs for them. And a lot of times these kids require sort of technical variants, which we'll get into a little bit later in the talk. With Dr. Rasmussen and myself, we'll talk about what does it mean to have a technical variant transplant. And as we talked about the waitlist mortality, it's roughly between 6 to 8% per year. But ideally, you'd like that number to be zero. And that's what, a lot of the work that's been done nationally by Dr. Rasmussen with the split community, as well as Dr. Sue and a number of other members of our transplant team, to try to put policies in place to decrease waitlist mortality. One of the most recent things that's been accomplished is in making sure that all pediatric donors primarily go to pediatric recipient first, and unless there's no pediatric recipients available, then it goes to adults. That's been sort of a major change in organ allocation recently. So as we talked about, majority of the kids on the wait list receive deceased donors, and a smaller percentage receive living donors. And this is one of the other areas that we're trying to focus on, to try to increase the number of living donation that's done to help to decrease some of this waitlist mortality. If you look at other countries, Middle East or in Asia, this slide would probably be reversed, where they primarily do a lot more living donors than they do deceased donors. And on the deceased donor wait list, I had mentioned earlier, most of the kids do receive whole livers, and that's probably the sort of older, sort of adolescent kids. The smaller children, those that are less 5 or less, are primarily receiving either split liver or partial liver. And those are what we call technical variants, because it's not a whole liver. You have to either use a left lateral segment or a left lobe in order to make these transplants work. And by definition, a split liver transplant means that you take, and I'll show you this slide here, you take a part of the liver and you use it in 2 recipients. So the left lateral segment goes into a smaller child. The right triseg goes into an adult. Now, regardless of how you do regardless of what kind of graft you receive, whole or technical variants, there's sort of 4 components that must be done. So you do need to have vascular inflow to the liver, so hepatic artery and portal vein. You need to have drainage of the liver via the hepatic veins, and also, as the liver makes bile, that needs to be drained. And so in this picture of a left lateral segment or a technical variant, this could either be from a living donor or a deceased donor split. This is what graphically that represents. So this is the hepatic artery going in, portal vein, the hepatic vein from the donor gets attached to the recipient's hepatic vein, and in the smaller kids, you have to do what we call a Roux-en-Y hepatocogenostomy to make sure that there's bile flow and continuity with the GI tract. So, as we mentioned earlier, again, this is the Achilles heel of transplant, where the organ demand outstrips the supply. And some of the strategies that I mentioned earlier for increasing organ availability, the use of living donation, technical variants, donation after cardiac death, which essentially means there's a donor um, that you have to withdraw support on and have to essentially wait for them to pass away and then conduct the organ procurement versus a brain dead donor who they're still attached to the ventilator and you can procure their organs, while they're still being sustained. And the big thing that we're going to talk about today as another potential option is domino donation. And just for some definition, as we talk about domino transplant, the domino procedure in general is a surgical strategy that is, characterized by taking a viable organ from a person who needs a liver transplant and using that liver into another recipient who also needs a transplant. And so, that's another potential way of increasing, organ supply. This was first reported in the cardiac literature, and most of this literature is in the United Kingdom. And they would initially take hearts from patients who had primary pulmonary lung disease, such as cystic fibrosis or primary pulmonary hypertension, and use these hearts into other recipients. And what they found is that, the initial short-term survival was worse. However, long-term survival was comparable as they were able to do this procedure and learn from their results. And some of the early short-term survival that were worse was sort of donor recipient selection. For example, a lot of the people who had CF were younger, and so you take a smaller heart and put it into a bigger recipient, and then so the outcomes weren't well. But once they realized and made changes in how they did their donor and recipient selection, the outcomes continued to improve, and there was not much difference compared to just a regular deceased donor heart transplant. So once this proof of concept was done in the cardiac, it was then applied to liver transplantation. Initially, this was started in the early 90s, and the diagnoses that they first tried this was with familial amyloid polyneuropathy, and this is a rare inherited autosomal dominant progressive disease, and this is associated with the mutation of transthyretin, which leads to a buildup of the sort of mutated amyloid fibers, which ultimately would damage peripheral nerves and other tissues. And the reason why they thought that this would be a good thing to start with it, this disease takes about 2 to 3 decades to occur, and another decade to become fatal. And so theoretically, if you'd use these organs and put it into someone with, say, a tumor HEC that was either out of criteria or they would wait a very long time on the transplant wait list, and there's a potential for these tumors to get out of control. If you would transplant these organs, by the time they would develop any sequelae of FAP, they would have a sort of a long, successful life with a liver transplant. And a majority of the transthyretin is produced in the liver, and it's been shown that liver transplant is curative. There's been some reports that some people have actually had early onset of FAP post transplant. So it's not sort of 100% that you're going to do well, but this is what's been done mostly in the adult world, and overall the outcomes are very good. So in terms of pediatric transplantation, what are some of the diseases that are used as potential domino donors? The most common one is maple syrup urine disease. There's also primary hyperoxaluria. Familial hypercholesteremia is also one of the other diseases that's been used for domino transplantation. And there are other metabolic diagnoses that have been considered, but the long-term data is not necessarily available, or the outcomes are not as well. But we're just going to focus a little bit more on maple syrup urine disease because that's the most common one that's being done and with great success rates. Oh yeah. So MSUD is essentially it's a rare genetic metabolic disorder that's characterized by a deficiency in the branched chain alpha keto acid dehydrogenase, and this is required to break down or metabolize the three branched chain amino acids, valine, leucine, and isoleucine. When this enzyme is deficient, these branched chain amino acids build up as well as their toxic byproducts, and they all accumulate abnormally. And in the classic or severe form of MSUD, the concentrations of these amino acids build up pretty rapidly. And if untreated, symptoms begin to emerge within the first 24 to 48 hours. Usually, these folks can have neurologic damage. And if left untreated, as I said, there's progressive brain damage, which is inevitable. And so, sort of historically, one of the reason why it's called maple syrup urine disease is there's a characteristic odor that can be detected in your urine or, airwax. This disease, has been managed or can be managed with, really restrictive, specialized diet. However, despite being on this restrictive diet, these patients are still at risk for metabolic decompensation, either secondary to infectious process, injury, or stress. And so, again, these diets are very restrictive, and liver transplant has been shown to be an effective treatment. And so, one of the things that Dr. Rasmussen is going to talk about is sort of the ethics around that. Again, I know the metabolic geneticists are managing a lot of these kids on these special diets, but then, they're always at risk of progressive neurologic injury. And, you have to sort of talk about what's the risk benefit of transplant. As transplant, of itself, it's not free of its own sort of complications, just from the operation or lifelong immunosuppression. Just briefly about primary hyperoxaluria. It's sort of in the healthy individuals, glycine is converted to glyoxylate via the enzyme PGT. When this enzyme is deficient, this glycine gets converted to oxalate, and oxalate builds up into the system, and because it's cleared by the kidneys, over time will damage the kidney and lead to kidney failure. And it also can be deposited in other organ system, eyes, bones, skin, and heart. And initially, these kids were transplanted, or patients with these diagnoses were transplanted with just kidney alone. But that didn't really solve the problem, because they still had the enzyme deficiency that led to further buildup of oxalate, and their kidney transplant would be damaged. So most of these kids, if there's any evidence of progressive kidney disease, they would undergo liver and kidney transplant. And the thing, as you think about domino transplants, is and why you can use these organs, even though they may cause problem in the domino donor, is that these organs are structurally and functionally otherwise normal. So if you did a biopsy, it would look totally normal. And most of these kids, when they come in terms of function, INR, bilirubin, albumin, all these levels are totally normal. And it's just that they're lacking some enzymatic defect. So again, as we discussed with primary hyperoxaluria, it's a rare metabolic disease, overproduction of oxalate. It leads to, mostly kidney damage from hyperoxaluria, nephrocalcinosis. And again, liver transplant is the only cure for the disease. Very few patients who receive liver transplant alone, because most of these kids already have, or patients have some evidence of progressive kidney disease. So simultaneous liver kidney transplant essentially is the best option. In familial hypercholesterolemia, there's essentially a buildup of the very low density lipoprotein. This is an autosomal dominant genetic disorder of cholesterol metabolism, and that leads to sort of early increased risks of cardiovascular disease in these patients. Now, this can be inherited in either heterozygous or homozygous fashion. Patients with heterozygous familial hypercholesterolemia can be medically managed very effectively. However, folks with sort of homozygous form of this disease, it's very challenging to manage medically. And again, liver transplant is the only cure. And again, sort of just to keep in mind, again, these livers are generally structurally and functionally normal. So I'm going to turn over this part of the presentation to Dr. Rasmussen to talk about, how can Domino liver donation improve the donor pool? She'll talk about some of the surgical techniques, some of the ethical considerations as you do this, what it takes to accomplish this operation, and the successes and next steps.
Okay, so we've had an overview of the status of pediatric liver transplant wait list, and now where does Domino liver donation fit into that? So as we already reviewed, the organ demand outstrips the supply, and this is data so far from just this year. So we're already over 2,000 livers short, and the transplant community has been very dedicated to addressing this shortage, and they've come up basically at every opportunity to increase the organ supply. As Dr. Dick already reviewed, technical variant grafts, particularly split liver transplant, can be used to sort of get a 2-for-1 save, where one deceased donor can save 2 individuals. In 2020, this was an underutilized technique where only 84 of the liver transplants that were done in the United States were actually split transplants. This is an exciting development that's coming out of clinical trials and was just presented at the American Transplant Congress last week. It's ex vivo machine perfusion, and it's going to have a huge impact on reconditioning marginal grafts from older donors and allow adults to get transplants that might otherwise not have gotten transplanted. Has not been used in pediatrics because usually we're not willing to compromise on graft quality very much. So of the third option for increasing the donor pool is living donation, and this is really becoming more and more common in the United States every year. You can see on the left-hand side here that in 2018, we were doing about 400 living donor liver transplants a year. By 2019 was a little higher than 2020. We all know why that was, the coronavirus pandemic. But here the pink line in 2021, we're already increased the volume of living donor liver transplant. So Domino liver donation, to emphasize, is just a specific subset of living donation. And to review the idea, we're going to focus on maple syrup urine disease because this disease is particularly applicable to pediatric liver transplant, and I'll review why in the coming slides. But you have your maple syrup urine disease patient who's been listed for liver transplant. Most of the enzyme that is responsible for the deficiency in MSUD actually resides in skeletal muscle. The liver only provides about 15% of the enzyme's biomass. So when you take the Domino donor, when you do the hepatectomy for your MSUD patient, you transplant them with the liver from a deceased donor that then supplies the MSUD donor with 15% of the normal amount of the dehydrogenase enzyme. You can then take MSUD donor's liver, and here's a picture, and transplant it into someone who does have structural liver disease and is dying on the wait list because they don't have access to other organs. And because they have the dehydrogenase enzyme in their muscle, they're not going to miss the enzyme in their liver. So a few more facts about MSUD. There's been a lot of advances in its management. It used to be in 1989 in the Mennonite population. So let me talk about the incidence first. In the general population, the incidence is 1 per 185,000 births, very rare. But in the Amish and Mennonite populations, especially in the eastern United States, the incidence is much more common. It could be 1 in 120 patients will have it. So the Amish communities deal with this condition regularly. The neurologic damage is, as long as they're well controlled on their strict dietary regimen, which is a carbohydrate containing formula, can be minimized, but no one gets to adulthood without some neurologic decline or damage. In the 80s, the incidence of death from this disease was almost 50%. And even with the improvement in management, it's common for these kids to have attention deficit hyperactivity disorder. And then the families live under the constant threat of metabolic crises, which can be fatal, and they can cause prolonged hospitalizations that require emergency hemodialysis and other supportive care. In 2006 dollars, the cost of the formula was $9,000 a year. So if your child has no trouble, no hospital stays, over 10 years, you've spent $90,000 on formula. If you had to be hospitalized in 2006, the hospitalizations could run from $100,000 to $600,000, depending on the support services that were needed. So that is the justification. You know, people say, well, why can't patients just stay on their formula? The reality is they're dealing with a lifetime of fear and significant comorbidities. It was actually serendipity that allowed people to discover that you could transplant MSUD and cure liver disease, or you could transplant MSUD and cure the condition. The University of Pittsburgh had an 8-year-old who presented in acute liver failure. She was known to have MSUD, and they found out that her family had been giving her high doses of vitamin A, and she actually had vitamin A-induced liver failure. So they listed her for emergent transplant, transplanted her, and then within a few hours of reperfusion, her branched-chain amino acid levels normalized in her bloodstream, and she was able to remain on a normal diet post-transplant. So how does the evaluation of an MSUD patient differ from normal? The addition of colleagues from biochemical genetics is key, both pre and peri-transplant and post, as well as the addition of a Domino donor advocate, which I'm going to talk about more. The usual suspects, coordinators, nutrition, pharmacy, cardiology, infectious diseases, surgeons, and transplant hepatology are also involved. So why the Domino donor advocate? This paper was put out in 2018 by some people at centers that were developing a lot of experience with Domino liver transplant. And they put forth that it's really important in Domino liver transplant to avoid 2 distinct ethical harms. The first is you don't want families to feel undue pressure to donate out of fear that if they say no, their child will not be listed for a liver transplant and will be less likely to be transplanted if they decline the Domino donation. And the second ethical harm you need to avoid is you don't want families to feel pressure to consent because they fear that even after that, they're not willing to take on the extra risks of the Domino transplant procedure, but they feel pressure to show deference to their transplant team. So to avoid these harms, the first thing that's recommended is that the evaluation and listing be completely separate from the Domino consent. so that the families know their child is accepted and they're listed, and then the conversation for Domino donation starts. The authors of this paper advocated for having a member on the team be a Domino donor advocate. This is not a requirement of the OPTN and UNOS, unlike the independent living donor advocate that is required for standard living donor liver transplant program. But the reason they advocate for the Domino donor advocate is they want someone with the appropriate knowledge and skills to help patients understand the extra risks and potential benefits and alternatives to Domino liver donation. This donor advocate needs to have the authority to stop the Domino donation if they find out in conversations outside the ones the transplant team that the family's just not comfortable with Domino donation. In the case of pediatric patients who are undergoing consideration for this person should have expertise in dealing with minors. The key difference between the ILDA and the Domino donor advocate is the independent living donor advocate works with a healthy individual who has no liver disease, who wants to donate part of their liver to a loved one, or altruistic donation is also increasing. They undertake the operation at their own risk, and they're going to get no clinical benefit. The Domino donor advocate is working with a family whose child has a chronic illness and whose liver is going to be removed whether or not they agree to Domino donation because it's required for liver transplant. So it's important that also that the Domino donor advocate not be involved in the evaluation of the potential Domino recipient. And this person should remain available to the family throughout the workup and waiting period. So how does Domino donation differ from traditional liver transplant? Well, first of all, liver transplant for MSUD is elective. So the alternative is always to not pursue transplantation. The risks are the surgery is going to be longer and it has to be altered somewhat to allow the Domino liver to be removed in such a way that it can be transplanted. Longer surgery means longer time under anesthesia, and it may mean alteration in the pre-transplant workup. There may be extra lab tests, extra imaging, and families need to be aware of this. They need to be aware that they may get extra testing because they're trying to pursue the Domino donation. They have to it be explained that the Domino liver may not be able to be used, it may not do well, and the Domino recipient may never wish to meet them. So what are the benefits? There are no clinical benefits to Domino donation, but there are some psychological benefits. The Domino liver patient is usually excited to think about their liver helping someone else. And there's benefits to thinking about that. And if the Domino donor and the Domino recipient do wish to meet, there can be psychological benefits to them meeting through a third party according to their institution's regulations. And then lastly, the Domino donor is helping address an organ shortage. So once the patient is accepted for listing and then called in for liver transplant, 3 operative teams are required, and timing and communication is crucial. The first team focuses on the deceased donor procurement. And in addition to safe recovery of the allograft, they have to recover extra vessels from the donor, either from iliac artery and veins, carotid artery and veins, because there's a very high chance that the Domino graft is going to require extra vascular reconstructions prior to transplant. Once the deceased donor team has visualized the liver and it looks good, they communicate to the MSUD recipient team and they begin their operation. I'll show results later that show the cold time here is stretched a little bit. So the MSUD recipient team usually wants to start as soon as they know they're taking the liver. They focus on the hepatectomy, and then the Domino recipient team is usually even one member is even in the OR with the MSUD team to receive the liver, to visualize it, and to accept it. And the Domino recipient team will start their transplant operation upon acceptance of the MSUD organ. So we're going to show you a video of the final steps prior to removing the liver. And if it goes by too fast, I have some still photographs to show you afterward. Let's see.
17-year-old with medical services. We're going to use the liver as a domino graft. So we have the prepared here the hammer. We're going to divide halfway. So vein here underneath. We'll divide halfway. DDA here. Primarily by location of the left and the right. This one has the wrong here. Going to do a patch. Going to do a full high cable. We'll do the cable here. And the upper cable we add all the cracks and make sure we bring the atrium down so that we give enough cuff for the other recipient. Okay? That's good?
Yep, sounds good. Okay, so just to recap what we just saw there, one of the technical aspects that's really emphasized is full mobilization of the upper IVC beneath the diaphragm to allow for good mobilization. So not for the Domino donor, but for the recipient, because you want to have enough cuff to do the implantation. It's very important to ligate the phrenic veins as they come off the diaphragm. That helps give you extra length, and sometimes a little widening of the diaphragmatic hiatus is required. This slide shows the lower vena cava, same thing. Draining branches are ligated with these silks, and they get as much mobilization as they can to the top of the renal veins. This panel C shows all the inflow that is been skeletonized and is ready for division. It's very important to note that for Domino liver donation, the circulation of the liver remains intact until you're ready to remove the liver. In normal deceased donor liver transplant, we might ligate these vessels as we're going along through the transplant because it increases the mobility of the liver. So just to recap, this is the bile duct. This blue vessel loop is around this portal vein, and this is the draining branch this is a feeding branch of the gastroduodenal artery that comes off the common hepatic artery. So all these things are transected midway through their length, with particular care being taken to divide the common hepatic artery at the level of the GDA. So the GDA is ligated, and that just allows a little bit wider of a landing spot for the new liver to be sewn into. Once this is all done, the donor will be heparinized, and then we clamp and cut. So the upper cava is clamped, the lower cava is clamped, all the vessels are divided, the graft is handed off to the MSUD or the Domino donor recipient team, and they do their back table work. We'll get to them in just a second. The Domino or the MSUD recipient's graft is sewn in a bicable fashion. So up to two more anastomoses for the cava rather than one, which is what we usually try to do. But this isn't a huge deviation. Some centers still do this in a standard operating fashion, and this is actually how Thomas Starzl started doing liver transplant. On the back table here, you see the Domino graft that's been flushed. The hepatic vein opening is here, sort of flush with the dome of the liver. So in this case, they had to take some of those vascular grafts that I talked about from the deceased donor procurement and attach them to the hepatic veins to make an adequate cuff for implantation. Once the MSUD patient has had their reperfusion, all the post-transplant care is the same as for any other liver disease, with the exception of periodic amino acid level monitoring. So that's a lot of work. How do we do with it? So there is an international Domino liver transplant registry that was started in the 90s that tracks every Domino liver transplant done in the world. And as of 2017, it had accumulated 1,254 cases from 66 centers in 21 countries. Most of the patients that received a Domino liver transplant in this registry are adults, and they are transplanted for all the diseases that Dr. Dick reviewed in his part of the talk. What was discovered early on is that occurrence of the primary disease in the Domino recipient is common for most diseases. And that is why Domino donors usually go into adults who have a very poor chance of getting an offer off the deceased donor list, have no access to a living donor, and whose primary liver disease has a pretty short expected survival. And the reason it occurs is it occurs in these diseases when the liver is the primary source of the abnormal metabolites that cause the disease. For maple syrup urine disease, remember that the bulk of the branched chain alpha keto acid dehydrogenase enzyme is in the skeletal muscle. So the Domino recipients aren't missing the enzyme in their new liver. That makes this organ ideal for Domino donation. And to date, MSUD is the only condition in which the index disease does not recur in the Domino recipient. There was initially concern that Domino grafts would not yield the same high quality outcomes as regular deceased donor livers. So this study that came out in 2018 queried first-time liver transplant in the UNOS database over a 14-year period. They did propensity matched Domino liver transplant comparisons to deceased donor liver transplant. And they found, if you look here, there's the middle line, 63,000 deceased donor liver transplants done in the time period. 126 of them were Dominoes. So they propensity matched them with a subset of the deceased donor livers. And you can see the Kaplan-Meier survival curves are quite similar. So this is a safe, viable option. The grafts are not inferior. So if the grafts are not inferior, oh, and then in the Domino recipients, as well as the Domino donors, the leucine levels stay normal. So this table shows the mean post-transplant leucine level for the MSUD donor and their recipient, the peak transaminases, which tend to be higher in the MSUD donor. The cold ischemia time tends to be higher in the MSUD donor than the Domino liver recipient. So MSUD patients seem to be ideal Domino donors. And the reason for this is that the disease does not recur and children have a higher death rate on the waiting list than other populations. Because UNOS policy has recently aligned to make it so that pediatric patients will receive priority for pediatric donors, it's in alignment with UNOS policy to consider how we can make Domino liver donors from pediatric patients available to pediatric candidates. The transplant community is very passionate about eliminating pediatric liver waitlist mortality. It's a national UNOS goal, and it would be appropriate to think about how these grafts can be used for children. But before we get worried about how we're going to run 3 operating rooms at the same time, let's talk about it some more. So the experience on Domino liver transplant for pediatric patients is limited so far. Most of the experience comes from the Children's Hospital of Pittsburgh. And in 2019, they published this small case series of pediatric patients who had different metabolic diseases. So carbamyl phosphate synthetase deficiency, propionyl acidemia, glucuronidase transferase deficiency, all patients with metabolic disease who could benefit from receiving a Domino liver from an MSUD patient. They also transplanted Crigler-Najjar patients. At the conclusion of the study, all the patients were alive with functioning grafts, and their Conclusion is that domino allografts for pediatric recipients can in fact be considered in select cases. So where do we go from here? Because of its complexity and its applicability in a rare population of patients, domino donation remains a very rare procedure in the United States. It makes up only a small part of the overall donor pool, but obviously it still represents a meaningful opportunity to expand access to liver transplant, especially to patients who might not otherwise qualify for an organ. Experience with domino liver transplant, especially in pediatric patients, has been concentrated in very few centers across the U.S. But we are excited to share that our domino program at Seattle Children's is almost ready, and we look forward to performing our first domino liver in the near future. As experience with this technique grows, centers are pushing the envelope even more. Now we have MSUD donors being reported as actual split liver transplant donors. And with this possibility, one deceased donor that goes to the MSUD recipient can benefit 2 people. So one deceased donor will transplant 3 people, I'm sorry, the MSUD recipient, and then the MSUD donor can be transplanted to 2 individuals. So domino livers are also being performed increasingly in a variety of situations. The case reports I found were quite varied and diverse. So we'd like to thank you for listening to this talk today. Hopefully, after our presentation, you can appreciate that liver transplant's an excellent opportunity to cure select metabolic conditions, especially when native liver function is intact, and those livers can be used to donate to another patient. Domino liver donation increases availability of a very scarce societal resource. It does require very complex teamwork and investment from the institutions and centers that are undertaking it. And then even though domino donation originated as a strategy for adult liver transplant, pediatric patients can benefit both from being a domino donor themselves, and select candidates can benefit from receiving a domino transplant. Lastly, outcomes from domino liver transplant are equivalent to outcomes from deceased donor transplant, and therefore domino grafts should not be eschewed as inferior. The domino transplant team at Seattle Children's works tirelessly to make sure our patients receive outstanding care, and none of what we've talked about today would even be possible without the hard work of all of the people on this slide. Our coordinators, NP, schedulers, social workers, nutritionists, pharmacists, and more. This is the team of providers overall at abdominal transplant at Seattle Children's Hospital. Dr. Dick and I both appreciate everything you do. I'd especially like to thank Dr. Healy for his mentorship this year. I can't tell you how I've thought about you as a role model since I interviewed here for fellowship in 2008. And Dr. Reyes, I thank you also for your mentorship, and I value the investment you both have shown in me this year. Anesthesia, hepatology, we can't name all these people. And then lastly, I'd also like to thank Kim Reilly for being a constant source of answers to my endless "how do you do this here" questions. She hasn't gotten tired of me yet. And I thank Dr. Dick and the Department of Pediatrics for the opportunity to speak today.
We'll now open up for questions.
Well, thank you very much, Sarah, Andre. That was a wonderful presentation. If anybody has any questions, I don't see much in the chat box, but we're monitoring that. I think at this point we have a few minutes left, so if you want to raise your hand, that's another way to get your questions. I can ask a question just for starters here. You know, one of the challenges is identifying a recipient for the domino liver. And what sort of What's different about accepting a liver from a Domino patient compared to a non-metabolic liver donor liver? How do you, are there any specific issues that need to be discussed, or is everybody on the waiting list just naturally available for the Domino donor?
That's a great question. Usually, patients are have a discussion with their transplant team about whether they'd be willing to accept a Domino donor, and a discussion of what that entails is had with the patient individually. And then, so just like they would get consented for a living donor or an increased risk donor or donor after circulatory death, it's just another pool of donors you discuss with them. Identifying the proper candidate, you want to minimize the chance that the disease recurs. You want to ideally identify a candidate who's size matched at a center that can work with you on the day of the operation. And you want to maybe try to steer that organ to someone who's not going to get an offer off the deceased donor waiting list.
Thank you.
Any other questions? I think one of the things I want to reiterate that what Dr. Rasmussen is saying is this is a sort of a resource intensive transplant that requires, you know, significant surgical sort of expertise, which we all have here at Seattle Children's. And you know, we sort of partner also with the University of Washington. As Sarah's mentioned, that, you know, you want to make sure that there's appropriate size sort of matching. And, you know, one of the things that we talk about, not just us, but sort of nationally, a lot of these organs are coming from younger, smaller patients. And in the adult world, women are sort of disadvantaged because they're very small. And it's also difficult to find whole organs for them as well. And so this is also, again, as Sarah mentioned, this is another way of not just increasing the pool for organ transplantation for kids, but for adults as well. And I know she had mentioned a slide where, you know, in a Domino donor you can get 3 transplants out of it: Domino recipient and the Domino donor. But, you know, potentially you could get 4 from a deceased donor who you split and use those organs in the Domino donor, as well as split in the Domino recipients. So just thinking of other innovative ways to expand the donor pool to try to bridge that gap between the demand and supply.
Yeah, from a programmatic standpoint, I think it's always important to try to engage the support of your administrative leaders, and we will be soliciting support of our surgeon in chief for this effort. So no, seriously, the impact on the operating room and staffing and on we don't take that lightly for sure, and it does require some technical excellence and experience from not just the clinical team, but in the OR staff, the anesthesia team, and that's something that's been building over the years as our teams have specialized, and that's been a great thing to get us into this position. All right, I'm seeing we'll give it another couple minutes here, or see if anybody else has any questions. At this point, I think if you want to just unmute yourself and ask a question, that would be fine. I don't see much in the chat box at this point.
Looks like we may have been too thorough in our presentation. There's no questions.
Exactly. Well, in closing, I'd like to thank you, Andre and Sarah, for an excellent presentation. Definitely introduced a new idea to the rest of the community here at Children's. We may be familiar with it in transplant, but actually one last question here. Jess Havens asked a question actually about the pump, about ex vivo perfusion pump. What do you see for that? Do you have any? The question is, will the pump be something that we start to see in the future?
Yeah. So I would say probably not. The status of the pump is the results of the multi-center clinical trial that was held only in adults were presented at ATC last week. And it's amazing. They can take these high-risk livers that had a high discard rate, and they put it on the pump for a few hours, and the steatosis starts to clear, the metabolites start to clear, and then they transplant, and the recipients have shorter hospital stays, fewer complications. I don't think it's something we're going to use in children too often, because we just would not accept marginal grafts for children most of the time. But I also have learned in pediatric surgery and transplant that you never say never.
One last comment from Rachel. The expertise and systems required are staggering. Thank you for sharing your gifts with the community. Appreciate that, Rachel. I think we're right up on time right now, so I want to thank everybody for joining, and again, thank Andre and Sarah for a great presentation.
Thank you, Dr.
Thanks,
Healy.
everyone.
Yeah, thanks, everyone.